Good afternoon, everyone, and very welcome to this webinar. Like I said earlier, I believe we had 800 registrations, and now we've got close to 400 people who's already joined the webinar, and I'm sure there'll be a few more. That's absolutely fantastic. And it just shows you that I think people are ready for a discussion around navigating telehealth in the current healthcare environment. My name is Lani. I'm a product manager with SpesNet Global Group, who also kindly sponsored this afternoon's webinar with the support of EZMed and Medici. Now, believe it or not, but I'm still a healthcare provider at heart. I studied physiotherapy many moons ago, and I actually practiced for many years, both in South Africa and overseas. And boy, I tell you, I can't believe the impact that the date 26 March 2020 had on me, both in my personal life, but as well as in my professional capacity. And I'm sure there's not one attendee today whose life has not been affected by that specific date. And where are we now? 56 days after that. I mean, what a roller coaster ride. I don't know about you, but I'm sure you've just been bombarded with information. And I can't keep up with everything. There's regulatory changes, the Council of Medical Scheme updates, there's communications coming from the Department of Health, there's insurance updates, and the list goes on. If you just look at digital platforms, daily there's publications on virtual health, telehealth, digital platforms, which one should you use, which one shouldn't you use. It is so difficult making decisions, and I really, really feel for you. Probably one of the questions that I get asked most often over the past couple of months is, I'm a practitioner, I need to engage with my patients over a virtual health platform. Can I use WhatsApp? Should I use SMS? Can I use my own phone? What about Teams? To Zoom or not to Zoom? That's the question. Guys, I really feel for you. I think a lot of healthcare professionals are in a very, very difficult position at the moment, because of all the uncertainty that's going on. I also know there are loads of you that had financial losses because you had to either close your practice completely or partially. And I know probably the majority of you that are on the call today are frontline practitioners who can see patients face to face in your practice. But that obviously poses challenges in itself. Excuse me. Today, hopefully, with our three panelists who I will be introducing shortly, we want to try and address some of these challenges that you are experiencing and to see how you can navigate telehealth to really help you try and solve for these challenges in your practice. We want to answer questions like, how does telehealth fit in my practice? How can I choose a reliable or a secure digital platform to perform my virtual consultations on? And also, if I do a virtual consultation, will I be covered by my malpractice insurance? Luckily here today to help me unpack and answer these questions, I've got three panelists. First of all, Deon. He's the director of ProfNet Medical and also the SpesNet Global Group Executive for operations. Deon himself is a physiotherapist. We actually study together. And Deon's got an incredible passion to solve issues and find solutions in technology for healthcare providers in South Africa. Deon has also provided fundamental solutions for HPCSA, the Physiotherapy Society, the Carr Association, and many more. And he's busy with a very big project for the South African Nursing Council. He's also been working relentless to perfect ProfNet's practice and patient management system called EZMed, who literally just recently launched a magnificent telehealth solution together with Medici. And guys, we're privileged enough today to have the MD of Medici Africa on board with us, Neil Kinsley. Thank you very much for joining us, Neil, and welcome.
Thank you.
Neil has got many, many years of telehealth experience behind him, both in South Africa and in the USA, where Medici is actually based in Austin, Texas. Neil has held numerous leadership roles at Discovery, and he's also the founding and the governing member of the Digital Health Association in South Africa. And last but not least, Kristy. Kristy Carr owns CFB Brokers. It's a specialist liability insurance brokerage who looks after medical malpractice insurance. And she's got over 8,000 healthcare professionals that she's looking after. Now, attendees, I'm sure you will all agree that there's a wealth of knowledge in the panel seats. And I'm sure there's going to be lots of questions. We've got 435, to be exact, attendees at the moment. If you've got a question, please pose it by using the chat functionality. We're going to try and get to as many questions as possible. But if we don't, we are going to compile a Q&A document, which we will post on our webpage, EZMed.solutions. Also, if I can just ask you, please use the chat functionality to indicate your discipline. We would really like to see who is joining us today for this webinar. Guys, and lastly, the webinar will be made available once we're done, and it will be released to you as soon as possible. I'm actually going to stop talking now, and I'm going to look in Deon's direction to kick us off. But please, this is an informal discussion. Neil, Kristy, chip in if you need to. I'm going to cast my eye on all the questions and try and get those questions to you as and when they appear. But Deon, over to you, please.
Thank you very much, Lani, and hi, Neil, and hi, Kristy. It's really awesome to finally be here. I think we've been absolutely blown away by the interest and the numbers that have shown up. So thank you to everybody who's taken the time out this afternoon to join us. What prompted this webinar was that as we've navigated COVID, I've received multiple calls from various healthcare practitioners. And reflecting back, you know, I get 2 or 3 calls a week at least, and reflecting back on the conversations, they have typically been people reaching out, just wanting to have a conversation around where they find themselves. I think there's a lot of isolation. There's a lot of insecurity about, am I doing the right thing? What am I allowed to do? What am I not allowed to do? And what do I do from here? My practice is taking strain. My patients are reticent to actually come into a practice. They're concerned that they will put themselves at risk. And what are my options? How do I actually navigate this? And what do I do? And as we've moved forward together with Medici and with Kristy, we often, pretty much on a daily basis, have conversations around what's happening. I think we can all agree, to Lani's point, that not a day goes by that something hasn't changed. And so we have conversations about, you know, what are the solutions and how do we mold that to meet the challenges that you're all experiencing. And as we're having those conversations, we reflect to ourselves saying, wouldn't it be awesome to have a webinar where people can actually just listen into this conversation? And I trust that's the tone we want to take in this interaction is conversational. This is not a lecture. It's not an academic exercise. It is conversational. We'll chat between us. We really want to be guided by your questions, your burning points. Thanks to those who sent their questions yesterday already. Some already getting ahead of the queue and sending those questions through. And we'll attempt to answer those. But we trust that this will become part of your weekly routine. We'll be running these webinars every Thursday from 4 to 5. The topics will be shaped by what comes up in our conversations and the elements that you guys raise as important, and whatever's developed over the week since we spoke last. We'll have different panelists. Lani will anchor this and bring in whichever experts we need to address the burning issues. And yeah, so we want to walk this journey with you. And we're going to plan at least the next 4 webinars. After today's webinar, we're actually going to regroup tonight. We'll post the next webinars up on our website. I think you guys can see that to register for upcoming webinars, EZMed.solutions. Just go there. You'll see which ones are coming up, and you'll be able to click and register there as well. So yeah, thanks for joining us, and thanks for being part of this journey as we navigate ourselves out of lockdown and into a new norm. I don't think we're going to be pushing the reset button and going back to how things were before. But that can form part of our conversation, and we'll try and unpack what the world looks like post-COVID and lockdown as well.
Yeah, I mean, I think you're right, Deon, and afternoon, everybody. Thank you for having me. I mean, I'm generally in quite the privileged position because I get to work with practitioners this side of the globe and then in the US. So, and it's really great because I get perspectives from both sides. And I mean, for me, I've been involved in telemedicine for a long time. And I mean, I know how everybody feels out there. It's daunting. And I have to tell you, I think we've moved on from the question that I'm about to pose. But the question that I hear a lot is, is telemedicine going to be around post-COVID-19? Or is this just for now? I think we're way beyond that. There's the platforms that have come out, the solutions, etc. And there's no doubt that practitioners out there are spoiled for choice right now. But it makes it extremely complex, because the question has to be, if I'm going to adopt this into my practice, what platform do I use? What are the questions that I should be asking of the solution provider that I know is going to give me the right answer and put a solution into my practice that's going to be for the long term? And that is, I think, what practitioners are surrounded by right now. But I have to tell you, this is just the most exciting time. It is so exciting for telemedicine. It is so exciting. And I mean, for me, and I think you can see I'm passionate about this, but I have seen practitioners that have adopted telemedicine in the last 2 or 3 months and have had absolutely no change to their revenue whatsoever, because they've used telemedicine in an efficient and effective way. And we've been very lucky to be able to guide them and assist them on how to do that. But I mean, it is so exciting right now. And folks, if there's one thing I can tell you, and if there's one thing I can leave you with this afternoon, is that telemedicine isn't going anywhere. Telemedicine is as old as the telephone. And that is the truth. I often come across practitioners that say, well, telemedicine is probably not something that I would adopt into my practice. And I pose the simple question, when was the last time you spoke to your patient via email or telephone or WhatsApp? And I say, oh, goodness me, I'm plagued by this on a daily basis. That, folks, is essentially is telemedicine. It's a dangerous form of telemedicine because, there's generally no record, no security, etc. But that is telemedicine. But it is so exciting. And I'm hoping to answer some of the questions this afternoon in terms of what should I be looking for in a platform? What are the questions that I should be asking?
Neil, if I can just add to that, is I think the challenge is you might be engaging in telemedicine, but very often that's a patient to your personal cell phone or email address. And WhatsApp is to your personal number usually. And that's a challenge, is how do you separate the professional relationship to a personal one? How do you ensure that you're keeping hours, that you're managing informed consents, and that you're following the rest of the ethical requirements while you're giving out your personal information? And that I think is a trap that I think many are falling into, and struggle to undo that.
It is. And I mean, I speak with practitioners on a daily basis, and I can't tell you the amount that I see that have their own personal cell phone, and they have a second cell phone that they use for WhatsApp. And I'm guaranteed out of the 446 people out there, there's at least a few saying, I know exactly what you're talking about, because that's what happens. And I have to tell you, it's so hard to get those people out of that habit of WhatsApping and emailing, etc. Because what has generally happened is that you've created this environment of giving away free clinical information because you don't charge for WhatsApp. So your patients expect to be able to send a WhatsApp at any time that suits them in an environment of an expectation of no payment. And this is so frustrating for practitioners. And I think that certainly in the last couple of years, I think we've come up with really sustainable solutions for that. You just need to find them and know what they are.
But Neil, before you carry on, Deon, if I can maybe ask you a question. Wasn't the HPCSA and the allied HPCSA against telemedicine or telehealth? What's changed?
So I think it's quite complex, and I was watching this with a lot of humor, because the first regulator that came out with a position or a revised position in the face of COVID-19 pandemic was the allied HPCSA, and great congratulations to them. They came out with a very well thought through amendment to their current regulation to say that in the face of this crisis, we need to do things differently. They in fact went on, I think it was on the 24th of March, where they came out and said, we're allowing telehealth, and we also making sure that that's available not only to patients who are established, who have an established relationship with the practice, but also new patients to the practice. Because if you consider how you're going to be managing COVID and possibly doing triage and so on, it might be patients that aren't known to your practice yet. And we all need to step up and be part of the solution. So that was their position. And not to be outdone, the HPCSA followed a day later and said, we're happy. Telehealth is permissible now. They've had their Telemedicine Guidelines, Booklet 10, out for going on 5 years now. And that booklet did empower telemedicine. But Lani, the difference there was they were saying that you could have a consulting practitioner who's dialing in to the actual treating practitioner who's with the patient. So your telemedicine, that was the word they were using then, was actually between two healthcare professionals assisting a patient. So that was typically for things like a second opinions or getting a specialist to give some advice to a GP that's working in a primary healthcare environment. So the HPCSA came out and said, firstly, we want to coin the word telehealth, which is all encompassing and includes things like telepsychology, telepsychiatry, and so on. And they used the word telehealth more broadly.
Yes.
But they were happy with that. But they said it's only the psychologists and the psychiatrists that can see new patients. For the rest, it's only on existing patients of the practice. And then a few days later, they had to redo that. There was a lot of pressure from various disciplines, associations, and societies. And they then published a new release to say, fine, you can do this with new patients that aren't known to the practice, but be sure you follow all the other ethical regulations.
And I think I read somewhere that the South African Council for Social Services, the professionals there, they also has a guideline out.
Yeah, they came out quite a bit later in April only with their guidelines, and they've coined the phrase e-social work. So they're also empowering social workers to work in the telehealth space. And they've got quite a detailed document about how we go about that. I haven't picked up if there's any social workers on this call, but I think it would be important to have a dedicated session on that should it be required, and we can get some panelists to speak about the social work specific environments. Because they're not only operating in a healthcare space, but under social welfare as well. So it'd be interesting to see how that unpacks, yeah.
Definitely. Neil, one of the questions that came up that I saw is that medical schemes might only pay for telehealth during the lockdown period. Can you elaborate on that?
So I think it almost speaks to the first question, which was, is telehealth going to be around post COVID-19 anyway?
Oh.
I think and this is my personal opinion, but I think it's going to be very hard to put the genie back into the bottle. We are doing thousands of consultations on a daily basis. There is no doubt that the adoption of telehealth around the world has saved lives. And I also have to make this clear. It's almost as if telemedicine is something completely new, and it only started, when the lockdown happened. This is not the case at all. People have been doing telemedicine, not even, and I already spoke about WhatsApps, etc. They have been using formalized platforms long before COVID-19. For them, this is just another day in the office. It really is. They've been using it forever, and they've adopted it into their practice, and they've adopted it in the best way possible. But I think that what will happen, and this is my belief, is that and we just don't have enough time, and this should be probably another session, but just to unpack the impact that telehealth has on medical scheme and the way that the reserves are utilized, just by way of preventing things like delayed care, etc. My strong suspicion is that medical schemes will continue to fund these in a regulated way, because there are certain concerns that schemes have, but in a regulated way, and they can control this via benefit design, etc. But I believe that they will continue to fund it post COVID-19.
So surely if we continue to fund it, sorry Deon for just interrupting you there. Kristy, I'm sure there's a lot of healthcare practitioners that's sort of, raising their eyebrows and like, what about their malpractice insurance? Are they covered? Are they not covered? Are there certain conditions that will be covered? Can you maybe shed some light on that, please?
Okay, certainly. If you don't mind, I'm going to try. Bear with me, everybody. I'm a technophobe. I don't know how many of you all watching this are also technophobes. This is really pushing the limits of us learning how to do things. So I'm going to share something, but something for those people that Neil mentioned that carry around 2 phones. I recently discovered that apparently you can get a cell phone that takes 2 different SIM cards, and you can actually make business calls off both. You can have one for personal and one for business. I thought that was really interesting because I know there's a lot of people that carry around 2. So I'm just quickly going to try and share my screen. Bear with me. Right. Can everybody see that screen all right? Lani? Right. Okay, so now I've got to remember how to move this table out of the way of the words. Okay, so when we're talking about liability insurance aspects relating to telehealth and COVID, it goes without saying that in the time of Corona, obviously your liability landscape has changed somewhat and continues to change as the situation develops. What am I talking about when I'm talking about liability? Insurance brokers and lawyers seem to have a tendency to use certain words, and we assume everybody understands them. I don't know if it was Deon or Neil who mentioned this. One of the big impacts that we've obviously seen is the impact on cash flow. So a lot of people obviously phoned us as CFP brokers saying, listen, what about loss of income? Is that covered under my medical malpractice policy? What we need to be very clear about when I'm discussing liability with you is liability insurance, your medical malpractice and your public liability, that covers your liability to other people. It doesn't cover your own losses. That would be a completely separate issue. So has insurance changed to keep up with the new landscape? Well, one of the first things that we saw was a complete scramble by insurers. Obviously a lot of people were on the phone, especially with regard to travel insurance. I'm really sorry. I know that there's probably a lot of people out there that probably had travel plans for this year, which you've had to cancel. You've probably looked into, whether the travel insurance would assist you. And there's been a huge scramble by the insurers, the underwriters, because this is basically an unprecedented situation as to how they were going to deal with it. So what a lot of them have done is, if they didn't have an infectious diseases exclusion on their policies in the first place, they have subsequently put one in there. So that's one of the first things, please, that you need to be aware of. A lot of the people that may be watching may be covered under CFP brokers wording, and obviously, I will talk to that. But even if you're not covered under CFP brokers wording, if you go and have a look at your own wording, you're very likely going to see something that looks like, I hope this is on the next screen. I don't know how to move the screens. Maybe Andre, can you help me if I want to go to my next slide? Oh, there we go. So this is on the CFP brokers wording, and you would find something that looks pretty similar. So this was in place even before COVID-19. And the reason that this would have come into place was obviously when HIV was a big thing and it came in, and your exclusion under your policy would look something pretty similar. And it basically says this policy does not cover liability arising out of any loss, damage, cost, or expense, directly or indirectly arising out of, contributed to by, the insurers love their words, as do lawyers, or resulting from any infectious epidemic, pandemic, etc. So please be aware, that's one of the first things, and perhaps when advantage of telehealth comes in. A lot of people have been contacting us. Let me try and move the slide. What does this mean for me? So a lot of people have been contacting us saying, so if one of my patients now alleges that they've caught COVID-19 at my practice, will my medical malpractice insurance respond to cover that? And the answer obviously is no, because there is a blanket exclusion on anything to do with COVID-19. And that is also regulatory bodies. If there's a complaint to the Health Professions Council, perhaps that you saw someone during a lockdown stage and you shouldn't have seen them, that sort of thing is just not going to be covered. Okay, so sorry, I'm getting into claims.
Well, Kristy, sorry for interrupting. Can I ask you, what about if you do a telehealth session with someone in a different country?
Okay, so with regard to that, again, everything is going to depend on what does your specific policy say with your insurers. So if we have a look at the CFP brokers wording and the ProfNet wording, anybody covered under the ProfNet, if we've got any chiropractors who are with Carr or anybody under the SAS policy wording, if you're consulting with someone in a different country, the insurers have said, looking at telehealth, you may do that so long as you have a jurisdiction clause in your informed consent that you obtained beforehand, indicating that if there is any dispute or litigation that will happen, that they will submit to South African jurisdiction. And the reason for that, you can imagine, it is a big risk, and I was very unpopular. I actually put this to many of the associations saying, listen, are you happy for your members to be rendering services overseas? Because at the end of the day, number one, we don't know anything about the laws in a lot of other jurisdictions. We don't know if you're going to be infringing on their regulatory guidelines, etc. And also, without tanking rand, sorry to depress everybody, hopefully you've all got some wine left to drink after this seminar or this webinar. If you get a claim from an overseas person, and let's say that it's in pounds, a lot of people might think that you could only claim the value in South African rands, but in terms of our law, if somebody claims, and let's say, for example, they now want loss of income, they would claim the equivalent in their own currency. So you can imagine, you look at the road accident fund, what was one of the things that sent them over the edge? It was a claim from a foreigner. So just please, everybody be aware that if you are going to be rendering services to anybody overseas, number one, you probably are dabbling in a jurisdiction that you don't necessarily know the legal rules. And number two, it's very important that you do have that clause in your informed consent that they do submit to South African jurisdiction.
Perfect. Thanks, Kristy. I want to bring it back home again. And Neil, I'm going to throw a question to you. Give us a bit of the juicy detail. What do providers need to look out for when they choose a telehealth platform?
Great question. And it's probably the question I get the most now. So I'm going to try as quickly and efficiently as possible to probably give you 5 questions that you should ask. And they're probably not the ones that you think. The first one is the obvious one. Got to be about data security. It doesn't matter what you do, doesn't matter what platform you're using. If you are not certain of your data security, you shouldn't be doing this. You know, don't let your telehealth platform be the cause of litigation for you and your staff at a later time. I mean, that has got to be the absolute basis for starting this. And I mean,
Neil, can I interrupt you right there? That's also really important from an insurance perspective. Please, everybody, have a look at your policies, because your medical malpractice policy, or at least the CFP one, does actually exclude any form of cyber loss. So although you can get cyber security policies, it's not something that you can bolt on to your medical malpractice insurance policy. It is something you need to look at.
Yeah.
Sorry. Yeah.
Absolutely. And thank you for bringing that point up, because I'm part of a number of different groups and Facebook groups and LinkedIn groups. And quite often, you know, people will say, well, have you seen this platform? And somebody will invariably say, are they covered by your indemnity insurance? And, you know, one thing I find is that often people will say, oh, that they've got end-to-end encryption. So they must be fine. I mean, end-to-end encryption is just the start of data security. I mean, for me, the gold standard of data security and data integrity is HIPAA laws, which are the American laws, but that is the benchmark. I mean, there's so much more just to end-to-end encryption. I mean, for example, is that at no point ever should you ever store video. That is one point, part of HIPAA. I mean, HIPAA includes administrative, physical, technical requirements. That has got to be the first. The second one is, how does
anyone know what HIPAA is?
So HIPAA stands for the Health Insurance Portability and Accountability Act. And it is the act, the piece of regulation to which all certainly US-based platforms, and then you've got the EU one as well. Our POPI was based on some aspects of it, but it is extremely stringent. It requires audits, which have to be done on a regular basis. Just for one of the things, for example, is that, I mean, any vendor that you might use, you should be able to ask them to give you some kind of partner agreement that holds the employees of a partner to the same high standard as they hold themselves to. That's one of the requirements. So it's extremely rigorous, and it's so important. You know, you just need one leak of data, just one. And
can I butt in there again, Neil, with regard to end-to-end encryption? This was another thing that went backwards and forwards. For any of you who are covered under a CFP broker's policy, you know, initially, I think Deon might be able to add something here, but initially the Allied Health Professions Council was incredibly clear that they did require you to use a platform which was end-to-end encrypted. And they were very specific as to the capabilities and specifications of the platform that you had to use. Whereas the Health Professions Council, there was actually quite a bit of dispute. Do I have to use something that's end-to-end encrypted? I mean, Deon, maybe you can speak about the ethical duties that everybody is still obliged to follow. And if we look at the Telemedicine Guidelines, which were pretty old, what they were saying, that it remains the practitioner's responsibility. But now, Neil, what about the fact that, what about if the person on the other side doesn't have much protection? When you could have the best protection in the world as the practitioner, but the other person on the other side has a computer from, Noah's Ark.
Well, I mean, you have end-to-end encryption, but WhatsApp is end-to-end encryption. And let's not forget that WhatsApp was hacked about 6 or 7 months ago.
Sure. Okay.
And we know, we did a bit of research about a year ago, and we found around the world 8 or 9 practitioners are using WhatsApp. And I'll tell you why. And this is going to bring me to my second point and the question that you need to ask. I'm going to give you the golden gem of telehealth. There are 2 types of telemedicine. One is synchronous and one is asynchronous. Synchronous is a video call. Both practitioner and patient need to be available at exactly the same time. So like we are here, we're using Zoom and this is synchronous. But some of the most efficient users of telemedicine have got platforms that do asynchronous care as well, which means that you're able to extend care to a patient, but both people are not necessarily around at the same time. Give you a great example. I'm getting older. I pick up running injuries from time to time. My physio gives me exercises to do. Instead of the 2 of us getting onto a platform like this where both of us have to be available, she does the video, shows me the exercise, she attaches the video to her telemedicine platform, and I can see that at a later time. I can then redo that and give her feedback. We're not on the platform at the same time. Now that's special. And why I love that is because it frees the practitioner up to see those individuals that they do need to see on a physical basis and still allows them to extend care to the others. So that's the second question you've got to ask, is that, does my platform allow for both synchronous and asynchronous forms of care? The third one I'm going to give you is the question you should ask is, and this is one of the biggest frustrations I think I see with practitioners, and that is, I love telemedicine, but my patients they just don't dig it. They just phone me and WhatsApp me, etc. Well, of course they do, because they've been WhatsApping you forever for free of charge. Here's the thing. Whatever platform you choose, there has to be some kind of offering to assist you to get those patients on board your telemedicine platform. How do your patients find out about it? I mean, just by saying, well, I'm now on telemedicine, your patients are not going to get into it. So there's got to be some kind of practitioner support, some kind of way of assisting to get patients into that system. So, I mean, that's my third one. And my last 2 that I'm going to give you is, most of the time, and we see a lot of these platforms coming up, mostly video platforms. I think we make the grave mistake of assuming that patients are quite comfortable with doing video consults. Do you remember the first time we did a Zoom meeting? It's uncomfortable. You see yourself on the screen. You don't look as good as you think you should. Patients, and we found that patients are not always mad about a face-to-face video consultation. You need, I believe, that a comprehensive solution requires calling and requires text as well, because there are times that call for that. And then finally, and this is the last question you need to ask, and it's a burning issue. How do I get paid? I mean, it is probably for one of this is why you do this, And practitioners have traditionally spent a lot of time giving away free care. How do you get paid for your time and your expertise? There has to be an inbuilt function somewhere along the line that billing must be done. Because if you are using great technology to deliver care and then not getting paid for it, it sort of defeats the object.
Can I jump in there?
I'd like to just talk about that billing, Kristy, as soon as you're done with your point.
Okay.
Yeah.
Okay. Something that I did want to mention, and please, everybody be very careful. I think that Neil makes a very, very good point about billing. But one of the things that we need to be pretty mindful of is establishing whether or not a telehealth consultation is actually appropriate in the circumstances, because funnily enough, I actually had a conversation with one of our underwriters. He's an elderly gentleman, he's in his early 70s, and he said that he's got disintegrating neck bones. And he contacted a physio, and they were basically pretty insistent that no, telehealth was the way to go. And the gentleman I'm chatting about is quite cantankerous, and he insisted that he actually needed manipulation. There was no ways that this was appropriate. So they ended that and found a physio who actually would do the necessary manipulation. And subsequently, a person from the original practice phones up to find out what he thought of the telehealth consultation. So he clearly said not very much. And then he got billed for both the follow-up and the original session. You can imagine he wasn't happy. This is the type of claim that you might have. I think it's very important to establish from the outset, is the telehealth consultation appropriate in the circumstances? And if that takes 5 minutes, not to go for it. Yeah.
Yes. I think one of the key things that the HPCSA has raised from an ethical concern is around overbilling or over-servicing, possibly even more so. So to Kristy's point, it's critical that we apply telehealth in the right and appropriate environment for the right and appropriate patient. I think the Allied Healthcare Professions Council has most certainly explained that you could even ask your patient on the other side to take their own pulse and their own temperature and feed that back. So I think that's a lot more relaxed than what the HPCSA might look at it from their angle. But it's important that it's appropriate. And here it starts spilling out into the billing side of things. We have to be aware that the HPCSA has made it clear they're going to review their position once the state of disaster is completed and we're out of this. But there's still a long tail to this, and I don't think it's going to just be because of the lifting of that. And we as healthcare practitioners need to be sure that we handle telehealth responsibly. And one way to ensure that is we need to be sure that your engagement with the patient is a formalized engagement. And this is where I have concerns again, where it's just an SMS or a message that goes through on your personal phone, is how do you actually then quantify that? Do you bring that into your billing system and your clinical notes? Have you got record of that interaction so that if later on somebody queries that and questions, you can say, I billed you for this telehealth consult, and here's the notes that accompany that, and this is the time these messages were sent, this is the time we had a phone call or a video call for, so that everything is aligned, and you've got the evidence of that interaction. We know what happens in medical scheme reviews, and the same principles apply, whether it's telehealth or general billing. Those rules don't change. There was a question around whether medical schemes in fact pay for telehealth, and the answer is most certainly an affirmative. They've been paying GPs for even before the COVID time for telemedicine. They are paying 100% to psychologists. When I talk about that, I think we're typically speaking about Discovery and some of the others that have followed their lead. And there are benefit designs around telehealth to empower that. So it's most certainly something that you can bill for and should bill for. As a healthcare practitioner, you're providing your professional engagements to that patient.
Deon, just one of the things that came up, I don't know if you want to mention it, whether this is really basic, but I thought it was important from a layman's perspective, was just to be mindful that you still have to use certain codes when you are billing for that, and that you can't bill for your time. If you've got an old lady who now takes 2 hours to understand what you're trying to get her to do, yes.
Yeah. So just on that point, it is important that you reflect your place of service code. And when that's electronically sent through, there's a 02 place of service code that indicates it's a virtual consultation. So that's important that you make sure that your practice management system is enabled to do that, and that is sent through to the medical schemes, whether it's paper claim or electronic EDI submissions. And then also be sure that the actual codes in some disciplines, they pay for all of the codes, especially the consulting disciplines, like psychology, because you are consulting. But in others, like what some of the schemes are called physical disciplines, they're paying for a subset of those codes, not all of your codes. And typically those that are more consultative in nature rather than physical interventions with the patient.
Deon, if I may just take 2 steps back. We were talking about the billing and claiming from medical schemes, but even before you see your patient, are you allowed to advertise that you can do telehealth?
So I think the first step is to take a step back, especially when it comes to the Health Professions Council, is that people are often quoting advertising and making professional services known regulation off an old booklet that doesn't exist anymore. So it is important that we make sure that our advertising is not misleading, doesn't cause unwarranted anxiety or distress to the public, that is not comparative in nature, that there's no touting or canvassing that goes with that. And it's also important to understand what we mean by touting and canvassing. Touting would be where you're putting forwards one element of your practice to try and gain other value to your practice. For example, a sign that says free Wi-Fi. is a favorite one that the current acting registrar of the HPCSA uses on stage. Free Wi-Fi has got nothing to do with your services. Now you're luring people into your waiting room to go onto Facebook and then trying to sell them clinical services. In my view, telehealth is not a touting element. It's a method. It's a mechanism of engaging with your patient and providing services, and it's another place of service type of setting. So if you're advertising that you do home visits, you do office visits, you've got a hospital or you've got rooms, outpatients, telehealth is another element to that and complements your services.
Perfect. Neil, I think I interrupted you. Were you going to say something?
No, I don't know. If I was, I can't remember what it was.
Oh, I think jump in there with home visits.
No,
sorry, Neil, you go first.
I tell you what it was. We were talking about billing. We still see this around the world, that the majority of telemedicine interventions are often not billed for. Because they are, there's going to be the situation where a patient may reach out to a practitioner and the practitioner says, look, I know what this is. You need to come and see me. This is not something that is appropriate for telemedicine, and obviously that's not charged for. But I will tell you, when, that happens quite often. And I had a very similar experience to this about 2 weeks ago. And my doctor did ask me to reach out to him on the telemedicine platform first, and I did need to go in. But the experience at the end was fantastic, and I'll tell you why, is that by the time I got to see my doctor, he already knew and he had insight into what my complaint was. So it cut down our face-to-face visit to probably 10 to 15 minutes, which would have been about half an hour. But I mean, Deon's point is well taken. You've just got to be, in terms of billing, I think your ethics and your experience would guide you in terms of whether telemedicine is appropriate or not.
Sure. Thanks, Neil. Sorry, Kristy, you were saying?
Sorry, just two things. From the insurance side, one of the things on our policy is that the insurers are insisting that you have to use a recognized and secure platform. So yes, telehealth currently is covered for the period of the pandemic, for those who have asked, but it is subject to a number of conditions, and one of the main ones is it has to be a recognized, so not a fly-by-night. Neil has mentioned how many are popping up at the moment, and it must be secure. So you would have to justify to the insurers that you have used and be able to have evidence that you've used a secure platform. And then just something with the mention of home visits. I don't know, Deon, I've seen something about home visits, and from what I understand, home visits are not allowed unless it's absolute emergency. I don't know whether that's for Allied Health Professions Council or Health Professions Council. I don't know if you want to say anything about that, because there will be people who are vulnerable, who perhaps don't want to come into a practice, and this is again something for them. You can't go and visit them at home. Yeah.
So I think in general, the ethics obviously allowing for home visits even prior to COVID is there. You are absolutely allowed to and enabled to do home visits. I think very often it's important to do that, to rehabilitate and manage the patient in their home environment and ensure that they're ready to be discharged back home, or that they're actually coping at home. So it would be up to the healthcare practitioner to actually weigh up the benefit versus risk to themselves, number one, and also to the patient, of course. And ensure that they follow all due regulation around the level of lockdown that we're under, as well as managing everything, obviously, from sanitizing, hand washing, and masks and so on. So there's other regulation that would come into that, and one would have to pitch and make sure that you're compliant with that. And then also, obviously, the territories you're traveling to actually go and see the patient. Kristy, you raised this morning in our conversation that crossing a metropolitan line, are you allowed to do that? And that is obviously then again against the framework of the level of lockdown that we're in. So one has to consider all of those as well when engaging with the patients.
But I think just be careful, because if I remember rightly, there is one of the councils has actually said home visits is not allowed unless it's actually emergency treatment.
Yeah.
Yeah.
Kristy, I just think on your previous point, I just wanted to loop back on that. So you're saying that the medical malpractice insurance policies, and possibly you can speak to your own as obviously a position of authority, is they do cover you if you're doing telehealth, and if they do, what is the questions around any excess payments that are payable for that? Is there additional risk to that?
Okay, so at the moment, the insurers agreed without on the CFP brokers policies not to ask for additional premium for people doing telehealth. They agreed to add it on, but they said, listen, We think that this is additional risk, and generally their position was when anybody wanted to do telemedicine, when a practitioner would come to them and say, listen, we want to do telemedicine, they'd have to fill out an individual application form, they'd have to pay additional premium, and the excess would generally be 10,000 Rand. So when we negotiated the endorsements that would add telehealth, it was agreed that although we couldn't have the normal excesses which apply, and usually your first excess would be about 3,500 Rand, but you have to pay for your first claim during the year, they said that because they saw the increased risk, it's 5,000 Rand for most of the practitioners that we do, except I'm going to be unpopular with our psychologists and counselors. Unfortunately, their excess is a bit higher. It's 7,500 Rand.
Mm-hmm. Okay. And is there a way to manage those excesses? Obviously, it's a risk versus a cost consideration. Is there mechanisms that people can do applications on specific systems to waiver that excess should their systems meet certain criteria?
So just to let you know that the underwriters did agree. They have reviewed Medici and the security documents, and they have agreed that in the event that the insured, or let's say a claim or a complaint arises out of telehealth, they will reduce the excess to the normal excess under the policy if that practitioner is a ProfNet member and was using Medici EZMed at the time of the telehealth service. So, you know, at the end of the day, it's a saving.
I think it's important that, because we've got quite a large forum, and I think those who get their medical malpractice insurance, we know you get it through ProfNet, but I don't think that's the point I want to make here. There are many that are members of different associations and societies that are in fact getting covered by your policy wording, those 8,000 that Lani spoke about in the introduction. Yes. Can you maybe just list those associations and societies that you are offering the cover through their membership?
Okay, so the ones, when I talk about the CFP brokers wordings, for those of you who don't know me, it would be the Optometric Association, it would be the South African Society of Physiotherapy, it would be the SAAA, which is the audiologists. I'm just trying to think, there's not on this group, but we also do occupational health nurses and the biokineticists. Sorry, one of my favorites, BASA, the biokineticists, yes.
There you go. All right.
So I see there's been some really interesting questions that have come through here. I just wanted to deal with one or two of them, if you don't mind, because there was the one, I think there are a few of them, and this one's come up a few times. The one is, what is the difference between telehealth and telemedicine? And actually, I just wrote an article on this for the CIPA Association last week, so it's still fresh in my mind, so I'll give you the answer. So you would think that they were pretty much the same, because they very often are used interchangeably, and people talk about telemedicine and telehealth as if they were the same thing, and they're actually not. So telehealth is more of a collective description, and it includes all forms of remote care, and that could be apparatus, it could be you've got remote blood pressure cuffs, etc. That is telemedicine is the actual delivery of care through a remote platform. So it's actually quite different. There's somebody else that's asked, is Zoom and WhatsApp? Somebody said WhatsApp is really great because it's easy to use, and that must be, I have to be honest, WhatsApp is probably the last solution that I may look at. It is easy to use, but it's certainly, and it's a great communication channel, but probably not for the exchange of clinical data. So in my opinion, probably WhatsApp is not the best place to be going to. I'll leave Deon to deal with Zoom. The question is Zoom safe to use in terms of telemedicine?
I think there's a question there that's just come up that says, can we recommend a platform to use for telehealth? I think in this case, you're asking turkeys to vote for Christmas. You can see who our favorites are and who we partnered. But Neil, I think what might be of value is if we put up a checklist, a physical checklist that people can run through, and maybe we can put that up on one of the sites and we can post that afterwards, that you can then use and go through and check it and challenge the person who's offering you a telehealth platform to answer those questions. And you can do your own assessment and decide from there. Is that something we can do, Neil?
Absolutely. Yeah. So I'm actually writing an article at present on exactly what you should be looking for and the questions you should be asking in terms of choosing a a telehealth solution, I'll be happy to pass it along, and then you can post it up. Absolutely.
Fantastic. I think we'll drop it onto EZMed.solutions where you'll find the other webinars and stuff as well, just so it's an easy to find spot.
Can I chip in there with regard to Zoom? I have to show some independence here. So just to let everybody know that initially, again, on the CFP brokers policy documents, the underwriters came out very strongly saying they were against Zoom. They actually had internal communications saying that none of their staff members were allowed to use Zoom. There was a lot of negative press around Zoom. I don't know if everybody's seen it with regard to porn bombing that was going on. I think subsequently Zoom has upgraded certain security features. The questions have been asked, will the underwriters automatically exclude any claim that arises through the use of Zoom? And it's still a bit of a wishy-washy answer. You know, you'd have to prove that you maximize the settings on your Zoom to have proper safety of your patient information. And also the underwriters initially did recommend certain platforms. Medici was one of them, but also Cisco WebEx, WhatsApp was recommended, and Microsoft Teams. But I don't know, some of you all have your own experience and your own favorites.
Sure. I've noticed that various people and regulators specifically have made certain recommendations. And I'm not sure if they're based on a full technical understanding of the requirements. And I implore each of you to actually just as participants, do your own homework, check against the checklist. Somebody's mentioned now as well that HIPAA's got its own checklist. We'll include that, of course, as well. And do your homework around that. Make sure that you've done your homework and that whatever platform you use, you're able to then bring in and ensure that your billing, your clinical notes, and the platform that you've used is aligned. And that you ensure that you cover all bases. You need to be able to be sure that you're accountable for that interaction and that it is done in a professional and a healthcare sensitive way. Where we must understand healthcare information on the internet is more sought after from hackers than credit card details. It is very sensitive information, and that's why you'll see such an attack on those spaces. So please understand, it's not just the fact that you got a patient and what treatment you've done. There's more to it than that. And where patient's information has been breached and the POPI Act kicks in, you've got a lot of work to address that breach. So protect yourself and protect the patient's information.
Absolutely. Kristy, if I may just pose one last question to you.
Yes.
Do insurers pose any specific conditions in the insurance? Are there any restrictions there?
Okay, if you don't, bear with me. I'm going to share a screen to answer this question, if I can now find it. Okay, sure. I'm just looking for what I needed, and of course it's not going to be here.
Just while Kristy's looking for that, I just want to give quick one-word answers on some of the one-sentence answers on some of those that have come up. The one just around the ethics of treating in another country. Both the HPCSA and the Allied HPCSA states that you can treat patients in another country, but be sure you're registered with the regulatory authority in both South Africa and that country that the patient is in, because you're under the ethical rules and regulations of that country as well, the jurisdiction. So it's not just your malpractice insurance policy wording, but also obviously the ethical rules. And then there was a question on video storage. The Allied HPCSA says that and I reviewed the wording again yesterday and have been sort of in communications with the Chiropractic Association too on this, is that they're saying you need to do video consultations and it has to be recorded. Now, one interpretation says that you have to actually save the copy of that video interaction, like we're recording this one now. My view is that you need to record that the session took place and have robust clinical notes reflecting what was done and decided in that session. To have to save the full data of those, you're going to get into data storage challenges, security challenges, and I think that position needs further clarification. The HPCSA does not state that you have to have recordings of video, and I'd almost caution against that. If I had to go to a GP in a face-to-face contact consultation, and he said there's a camera up in the corner that is recording our interactions, I can tell you I'd behave very differently and I'd be very concerned as a patient. So why would that be different in an interaction like this one? So the jury's out on that one, but the Allied HPCSA would need to clarify their wording on that.
Thank you, Deon. I'm going to give Kristy a quick opportunity and then we do need to wrap up because it is 5 o'clock already. Kristy, over to you.
Oh my goodness. Okay, can you see that? Can you see what I'm trying to share? Okay, so with regard to the specific obligations, sorry, I can't see my face on the screen. I've just got the document here. So with regard to the specific obligations that you have in terms of your policy, please go and check your own policy conditions. And there will be something that have been added, usually by something that looks like this, an endorsement, which deals with it adds on additional conditions that you need to abide by, including the ones that you already have. So I'm not going to go through this whole thing. This is the one that I'm showing you at the moment, is the one for ProfNet members, and I'm going to go through some of them. So for example, I've highlighted these things. The underwriters have said that they don't want you looking at their requirements of you in isolation. They actually want you looking at booklet 10 of the guidelines for good practice and adherence to the provisions of the ethical rules, 27A of the ethical rules of conduct. So there's other things that you need to be complying with. And then notice this where it says the extension of cover will be subject to compliance by the insured. So if you don't comply with these conditions, there's just no cover. So a lot of it has been repeated out of the guidelines and regulations that have been published by the Health Professions Council. This one, I'm only going to deal with the Health Professions Council because obviously the Allied Health Professions Council has something different. But as was mentioned earlier, the Health Professions Council did come back and say, okay, you can now deal with new and existing patients. However, what we must bear in mind with telehealth is this: provided that such consultations are done in the best clinical interest of patients. That's really important. Then we need to look at number 3. In keeping with existing health laws and regulatory requirements, informed consent must be taken from the patient and documented in writing prior to the provision of telehealth services. Again, that's important. Number 4, the insured shall in advance provide the client with certain information, including information about the nature and objectives of the treatment services concerned, including the cost of telehealth treatment. So that's another important thing. You know, people may think, oh, because it's telehealth, I'm not coming into your practice, I'm going to end up paying a lot less than I would have if I came into your practice. And a discussion needs to be had as to what you're likely to be billing them. Something else, we mentioned the recording. Neil indicated that he's against storing of recorded information. Please bear in mind that as far as I'm aware, if you're a chiropractor with the Allied Health Professions Council or you register with the Allied Health Professions Council, it is a specific requirement that you do have to record your sessions. That is not a requirement with the Health Professions Council, but in terms of the conditions of contract, it does state that if you are going to record your sessions with your patient, you have to first obtain permission from them. So I won't read through that whole thing, but again, it just comes down to, for example, maintaining the confidentiality. That is incredibly important. If we look at number 9, sorry, Lani, you asked the question. There's a whole things here. Okay.
We do need to wrap up, though.
Okay, if you can just give me, I'll go to number 11 and then leave it at that. Okay, so all electronic transmissions must be secured using generally acceptable data protection and authentication techniques, and must also be stored and filed securely for no less than the time period following which claims relating to the service may become prescribed, plus 2 years. So for those of you, what does that mean? You know, for may become prescribed. For those of you who don't know, there's something called legal prescription. And in terms of legal prescription, the general rule is that a person has 3 years from the date, not that you entered the service, but from the date that they've become aware that they've suffered harm. They've got 3 years within which to sue you. That is called the legal prescription period. If they don't sue you during that time, you have a defense. If they bring it in the 4th year, you have a defense in terms of the law that you can plead that their claim has actually prescribed. Please bear in mind, any of you who are treating children or anyone who's lost their mind, that prescription does not run against minors. So if you're treating children, a child's claim only prescribes either 1 year after they reach the age of majority, or they also have the 3 years from the date of treatment, or from the date that they become aware that they've suffered harm, whichever gives them the longest. And then you see all of this information that you have to still be keeping. If you have a look there, A through to G. Then there's no cover for any IT-related risks, and the policy will not respond if the connection fails while the medical practitioner is providing the patient with advice, no matter what the cause of the connection failure is. So please, people, again, when you're discussing and getting informed consent, it's very important that people know that there might be a break in transmission, and you need to think about it beforehand. How are you going to deal with it if there is a break in transmission? Do you have the phone number? Have you told your patient, please keep your phone by you so that we can connect again if there is a break in the transmission between us? And also you need to think about how you're going to be billing that sort of thing. Something that I want to bring up, please.
Last one.
Okay, this came up with the physios. Is we need to bear in mind as well, they brought it up in connection with a child, for example, who might have fallen down on their bum and is now bruised. And now there's perhaps someone wanting to do video conferencing to show the part of the body to show that the bum is bruised. Please be very mindful of potential infringement of pornography regulations, you know, with doing something like that. It's really important that you don't, I'm going to stop sharing here now. It's really important that you don't share parts of the body. I don't know if Deon has anything to add to that from an ethics point of view.
Yeah. Look, there's a lot to talk about there. I think we could possibly have a dedicated session purely on ethics and record keeping. I'm hearing a lot of that. How long do you keep records? What records can you keep? Can you forward on videos to the patient? How do you protect your own property when you're sending a video on? So thanks for that question. So perhaps we can put that on as one of the, what we'll do after this is accumulate all the common questions that we haven't been able to answer and have dedicated sessions on that. Lani?
But yes, Deon, I do believe we have run out of time. We're over by 6 minutes, so I have to call it a day. But what I can really sense here is that A, people are interested to get information. B, there's a wealth of knowledge out there that I think people like Neil, Deon, yourself, Kristy is prepared to share with the audience. And guys, do remember that this is a series of webinars. It will be same time, same place, next week, Thursday. And like Deon mentioned right at the start, please log on to EZMed.solutions. There's a webinar section where you can physically go and register. So don't wait for the invitation this time. We had such an overwhelming response. So we're putting the driver in your hands and you can go and register. We were thinking that, you know, we discussed a lot of the current telehealth environment today. So maybe one of the next topics can be the future of telehealth. And the other thing that we also definitely need to address is cybercrime and how can you be a little bit more cyber savvy and cyber smart. So look out for the topics on the webinar page and also for the panelists. We will definitely try and collate all the questions that you asked for us today and see if there's a trend. And we might get some really key opinion leaders to join us for some of our future webinars. I would just like to thank the three panelists from the bottom of my heart. Neil, Deon, Kristy, thank you so much for your time and effort today. It's been absolutely magnificent. For all the attendees out there, I really hope this has given you a little bit of food for thought and maybe just made you a little bit easier, a bit more comfortable, and knowing that there are people out there that can help you. So please contact us if you do have any questions. And like I said, we will answer your questions in a Q&A sheet that we will publish on the website itself. Also, great thanks to SpesNet Global Group. I know we've got some of the board members with us today who joined us. And definitely for EZMed and Medici, who literally just partnered for a magnificent telehealth solution. So guys, watch the press for that. And please contact us if you need any more information. That's it for me from today. Thank you everyone for attending. Stay safe and we hope to see you soon again. Good night.